Could sit down, please. We have a spectacular panel right now here, and as soon as you sit down, we will get to it. So thank you. Folks, you're going to be in for a big treat today. This is one of our highlight panels for the conference. And I don't need to do much of an introduction. All of you know the person I'm going to talk about now, but it is Dr. Roger Glass, great friend of CUGH, great defender of global health, great global activist, great global citizen. Dr. Roger Glass, as you know, is the head of the Fogarty International Center. So Roger, the floor is yours.
Thank you, Keith, and thank you all for coming on a Saturday afternoon here in Washington. I'm really delighted to be here with this panel of 4 Institute representatives, 3 directors, and Pamela Collins, who runs the global health activity in the National Institute of Mental Health. Our 4 presenters, Doug Lowy, who's the acting head of the National Cancer Institute, Tony Fauci, America's physician in charge of the National Institute of Allergy and Infectious Diseases, Pamela Collins from the National Institute of Mental Health, and Gary Gibbons, head of the National Institute of Heart, Lung, and Blood. So nice to have them all here. And the focus of this is on research priorities. And think for a moment, how many of the improvements in health today in the world are attributable to new ideas and advances in research? And secondly, how much of the research we're going to be doing in the near future will rely upon or depend upon partnering with scientists, researchers in the developing world to accomplish the goals of advancing the research agenda. So that's really the target of the discussion, research. And NIH, as you know, is the largest research funder in the world today. I think about half of the funds of NIH are dispersed by the 4 institutes that are up here. So you have a chance to ask your questions at the end of this session. Now at Fogarty, you know that our priorities are in training and capacity building in global health. And we work really with all of the institutes to provide platforms for research, ethics, research management, and training of young people in global health. And you've seen so many people with their green bands on here. I think we have some green bands up here as well, who are partners with us in the global health agenda. So let me move on to tell you about the 4 speakers. Each of them has an institute that addresses the most important causes of death, disease, disability in the world today. When we had a meeting at NIH about 8 years ago that Tony and I hosted, we brought up the head of NHLBI at that time, and he got up and said that the #1 cause of death in the world is heart disease. And then we had the head of NCI at that time, and he said that 85% of cancers in the world today are in the world today are in low and middle income countries. And then we asked who was responsible or who owned the greatest number of DALYs on the global burden of disease, and it was in mental health. So we have all of those partners represented here. So with that, let me just make a few comments, an introduction, and I think I was going to start with Tony Fauci, who really needs no introduction. Tony's really the nation's physician. Since 1984, he's been the director of NIAID and oversees research on all the infectious diseases. He still practices medicine, runs the laboratory, and is really responsible for us being here today because global health really emerged as a priority around PEPFAR. And Tony was really one of the key architects of that program in the Bush administration. So we really have Tony to be thankful for this meeting. He was also the recipient of the Gairdner Award that was given at this meeting in San Francisco last year. So it's nice to have you back, Tony, to speak with us. He's received so many awards, I don't need to begin with the President's Medal of Freedom, the Lasker Award, the President's Medal of Honor, and the like. So Tony, tell us where the priority should be as we go forward in the next decade. What's the next epidemic on the horizon? And how is it critical that research for your institute works and partners in the developing world. Thanks so much for all of you for being with us.
Thank you very much, Roger. It's really a great pleasure to be here with you this afternoon. Roger mentioned that we're wearing this green band for the Fogarty International Center. So I want to ask the audience a question. How many of you believe that the Fogarty International Center is absolutely essential for our research on global health? Woo! How about that? That's not going to get me in trouble, is it, Roger? No. Okay, so Roger asked each of us to just spend a couple of minutes setting the stage for what I think will be an even more fun experience of discussions back and forth in question. But as Roger mentioned in his introduction, global health goes well beyond infectious diseases, as he illustrated when he was referring to the responsibilities that each of us have in our own discipline. But I'm going to talk fundamentally about infectious diseases for the obvious reason that I'm the director of the Infectious Diseases Institute, but I do that with full appreciation that when you're talking about global health, that infectious diseases is only a part of that. So if you'll bear with me to being somewhat provincial about just talking about infectious diseases, it's because it's what I do. Prior to this, when Roger was communicating with us by email about the kinds of things we'd like to accomplish this afternoon, he asked us a couple of questions, and I want to just seize on one of the questions which I think is relevant to the discussion today, when he said, can you identify anything that happened in your career as the director of this institute which turned you on to the concept of global health, as opposed to just infectious diseases as they might apply in a very restricted way to our country, the United States of America. And I reflected on that, and it became clear to me how that all evolved, because I always had a feeling of the importance of the globality of infectious diseases, but never really as much until the very early 80s. Some of you may know I became director of the National Institute of Allergy and Infectious Diseases in 1984, so I've been the director for 33 years. But 1984 was a very interesting time because that was the first couple of years of the HIV/AIDS pandemic. And during those early years, it was felt, because the first cases were reported in the United States, first from Los Angeles with the first MMWR in June of 1981, and then the second one in July of 1981 from LA, New York, and San Francisco. And at that time, it was thought that there was something peculiar about the gay population in the United States. And it wasn't until a couple of years later, when Tom Quinn and Peter Piot and others were in Africa and showed that the same disease that we were talking to be as a gay-related United States disease was actually a disease that had already permeated sub-Saharan Africa, and we were just seeing the tip of the iceberg. And it was the involvement with HIV/AIDS as a universally global disease that opened my eyes to the globality of diseases throughout the world. Because when I went to Africa soon thereafter to see what Tom and his group had been doing, it became clear that not only was HIV/AIDS a devastating, evolving, and emerging pandemic, but there were so many other problems there that we sort of appreciated but didn't quite appreciate it. All the issues of malaria, of tuberculosis, and other diseases that are so devastating to countries that are still developing. So we put together a program back in my first couple of years of turning the Institute into really an institute that looks at infectious diseases from a global health standpoint. And it's really interesting when you do that, because we're all talking about emerging and re-emerging infectious diseases, which I'll get into in a moment. But I tend, and some of you may have heard me speak about this, when I talk about infectious diseases, which, as you know, kills, of the 56 million people who die each year on this planet, about 16% of them are from infectious diseases. And there's a great disparity, because if you look at DALYs in different regions of the world, and if you look only at certain regions, such as in sub-Saharan Africa, from birth to about 40+ years old, infectious diseases are unequivocally the leading cause of DALYs. But in other areas, it's not, as would be expected, because we've made major advances in infectious diseases. But when I break it down, you break it down into established infectious diseases and emerging and re-emerging infectious diseases. The established ones, as I define it, is one that you can give a good prediction, almost always very accurate, of the morbidity and mortality next year. So if you look at things like respiratory illnesses and death, diarrheal diseases, hepatitis, and HIV/AIDS, which 35 years ago was an emerging infection, which is now an established infection, it's highly predictable. But global health then takes on a new nuance when you think of what we have been experiencing forever, but we're concentrating it on very much right now, and that is emerging and re-emerging infectious diseases. Because if you just look over the last, and I had the opportunity to do this in a very unusual circumstance, take a look at what might be expected in the next year for emerging and re-emerging infectious disease, and that's all about global health. It's not just about the United States. And the circumstance that I was put in for that was right at the transition, following the election, but before the inauguration. Dennis McDonough, who was the chief of staff of President Obama, asked several of us to brief the incoming, not yet confirmed cabinet of the Trump administration about what they might expect in the first year of the administration under 4 scenarios. One was a real terrorist attack with bombs and bullets. The other one was another Hurricane Sandy. The third was a cyber attack, but the fourth was an emerging infectious disease that likely would emerge from someplace else on the globe. And that's what I did. I spoke to them about all of the emerging infectious diseases, and I went down through the first time I stepped into my current role. When Ronald Reagan was president, we had HIV. And then we went to George H.W. Bush, and we had a variety of other diseases. And if you look down through the diseases that are global health issues that either greatly impacted us here in the United States, like HIV/AIDS, that had some impact, like West Nile and chikungunya in our own Americas, that had impact other places like MERS, that has a cloud over all of us about the emergence of a pandemic flu, which when Obama became president, the first thing, it was very, very interesting. Some of you may not appreciate it, but when Obama was inaugurated in January of 2009, 3 months later, we had the first pandemic influenza of the 21st century. And he used to joke about that with us, with myself and with Tom Frieden from the CDC, about every time he turns around, there's an outbreak of an emerging infectious diseases. So he became very, very interested in the concept of global health. And then what I really did at the end, when we were discussing this with the incoming cabinet members, we impressed upon them the importance of our taking very seriously global health. So Roger said to speak to 5 minutes. I've been speaking for 4 minutes and 48 seconds. So I will stop in a few seconds and just tell you what I really wanted to emphasize the message, that global health is integral to really everything we do at the National Institute of Allergy and Infectious Diseases. And what we will be looking forward to over the next 4 to 8 or even beyond years is a total commitment to the fact that we have to address global health issues in a very serious manner. So I'll be happy to discuss later questions with you. Thank you.
Tony, great way to get us started. Next, I'm going to ask Pamela Collins, who's at the National Institute of Mental Health. Pamela is a psychiatrist with background in public health and epidemiology. She worked in New York on aspects of HIV epidemic and mental health among HIV patients, and she's taken that to the developing world. When I came to Fogarty, and we had one of our early board meetings, I asked Arthur Kleinman, who was on the board, to debate with Tom Insel, the head of NIMH, about the value of global health in the world for mental health diseases. And after that debate, Pamela was hired and brought on. She began a Delphi exercise of grand challenges in global health, which she's pursued to the point where the Canadians have put in a Grand Challenge Canada with money for global mental health. And the World Bank last year, with Pamela's involvement, had an agenda for global mental health within the World Bank's activities. So Pamela, you've come a long way to move the global agenda on mental health activities. Tell us about it.
Thanks, Roger. It's a real pleasure to be here. So when Dr. Fauci was starting at NIH, I had finished high school a couple of years before then. But actually in 1987, I had my first global health experience, and it was also with the AIDS epidemic. I was working in Haiti with Bill Popp and his group, and interestingly, 10 years later, I found myself working in South Africa, but focusing on HIV prevention for people with serious mental illness. Because in the United States, this was a group that had a much higher prevalence of HIV than the general population. And we began to work in South Africa at a critical time when, under the new democracy, there was reform in mental health services, they were deinstitutionalizing, building community health services, but at the very time that there was a growing AIDS epidemic in the 1990s. So here was another vulnerable group that, in fact, did have very high prevalence of HIV infection. And what struck me at that time was that these are shared problems. And I remember on a particular trip to South Africa discussing with a group of providers working at a psychiatric institution, showing them the kinds of behavioral interventions we were doing in New York for people with serious mental illness. And someone said to me, "Oh, you were coming from North America. We thought you were going to bring this high-tech intervention that didn't make any sense for us, but the people you work with have the same problems that people we work with do." And we realized that, yes, in fact, when you're talking about very vulnerable people living with chronic psychotic disorders, people who are marginalized, people at risk for HIV because of that, there are shared problems, and it helps to think about the solutions from very different contexts, because maybe we can find something new and find some answers. So I want to tell you about 3 reasons why we in the mental health community need to conduct global mental health research. First of all, the burden of mental disorders is large and it's growing. We keep learning that from the Global Burden of Disease studies. Second of all, we need to understand the etiologies to these disorders. This is the grand challenge, is how do we understand the etiologies in order to have effective preventive interventions, in order to have the most effective treatments that we can. And third, we need evidence-informed methods to actually improve access to and utilization of those treatments that are available right now and that work. And I'm just going to say a little bit about the 3 of these. So in 2015, there were an estimated 43 million adults in the United States with a diagnosed mental disorder in the last year. And that represented about 18% of all US adults. For children in the US, between the ages of 8 and 15, an estimated 13% had a diagnosable mental disorder in the past year. So these are highly prevalent disorders, and it's critical that we support the best science that's relevant to our amazingly diverse population in the United States in order to effectively treat and prevent mental disorders. And this is our goal at NIH, to, of course, generate the research that's going to inform the pathophysiology of these disorders, that's going to help us understand the trajectories of mental illnesses, that will help us develop and refine new treatments and prevention strategies, and ultimately will have the biggest public health impact. As most of you know, yesterday was World Health Day, and the focus of World Health Day this year was depression. Depressive disorders are now among the leading causes of disability globally, and as a group, what we used to call neuropsychiatric disorders, or mental, neurological, and substance use disorders, are the leading causes of disability, and these affect populations everywhere. So even if we were just to look at major depressive disorder alone, it distorts cognition, it disrupts sleep, disrupts eating behavior, increases risk of suicide. But depression also commonly occurs with other disorders, with cardiovascular diseases, with cancer, with diabetes, with HIV/AIDS, often increasing the morbidity and the mortality associated with those disorders. So we're understanding the extent to which depression not only increases disability, but that is also associated with greater mortality. So that's the burden issue. Number two, understanding the causes of mental disorders means that we have to engage diverse populations with a diversity of social experiences, with a diversity of environmental exposures, with a diversity of genetic risks in order to get at the mechanisms of these disorders. You may know that these are specifically disabling disorders of young people. So they account for a significant proportion of the burden of disease among people between the ages of 15 and 49. And in fact, many of these are conceptualized as neurodevelopmental disorders. So a huge challenge for all of you people who are beginning careers and thinking about what to do is, how do we actually understand how the brain develops? How do we understand how it functions in order to understand the etiologies of mental disorders? And if we take the examples of autism spectrum disorders and the examples of schizophrenia, well, let's start with autism spectrum disorder. We know that this is a highly heritable disorder. We know that it occurs globally. And we now know that there are dozens of genes that increase risk for autism spectrum disorders. But importantly, the advances that we've made in psychiatric genomics just in the last decade have occurred through collaborative research that's engaging scientists around the world. So NIH supports the Psychiatric Genomics Consortium, which brings together researchers from 60 countries around the world in team science. And we're supporting genomics research in Africa. One of our projects is part of the H3 Africa, Human Heredity and Health in Africa. And it's enabling us to identify risk factors for schizophrenia in the Xhosa population in South Africa. And why is this important? Because we don't understand enough about the genetic basis of schizophrenia either, and yet we know that given the genetic diversity in African populations, one might expect to find genes for schizophrenia that have not yet emerged from studies of other populations. And these kinds of data are not just relevant to one ethnic group, but they actually move forward our understanding of these severely disabling conditions. So this is another reason why we have to do global research. And then number three, improving access and utilization of what we know works by exploring different models of care and understanding the barriers to those kinds of care. So we do have effective, feasible treatments for mental disorders, but there are some universal challenges in this category too, and I think this is also a place where we have a role for global research. So if we take the example of depression and depression care, NIH supported the World Mental Health Surveys, which was a survey of 21 countries, understanding first the prevalence of mental disorders, and these include, the US is actually one of those countries, as are a number of low and middle income countries. But in addition to prevalence, this study also looked at the utilization of care. And there was a recent analysis that was kind of pretty disheartening, which showed that when you look at the data from these 21 countries and look at depression care, the majority of people around the world, whether you're in a high-income country, a middle-income country, or a low-income country, do not receive minimally adequate care for depression. In high-income countries, the number that received minimally adequate care is around between 20 and 25%. And it gets all the way down to less than 4% in low-income countries. And so the group explored this by examining whether or not people recognize the need for care. People may go for an initial visit, but do they receive quality, evidence-based care when they remain in care? And the answers to these questions vary across settings, and they also vary across subpopulations within the United States. So what we learn in settings of varying resources and varying cultural contexts can inform the range of responses that we can utilize at home as well. Another challenge in the United States, which you may or may not realize, is that we also have a shortage of mental health human resources. And this is a need shared by many countries around the world. And at NIMH, one of our emphases in our global research has been to support research on task shifting, on more abbreviated training for providers to deliver evidence-based interventions in mental health. And so this can inform us about what kinds of providers, be those community health workers, be they nurses, be they peers, what kind of providers can deliver interventions most effectively, and what models of training and supervision are needed to ensure quality care, and how this quality care can be deployed. And I want to mention two more things. Another shared challenge is our need to understand how the risk of and the reality of social exclusion, shame, and social stigma associated with diagnoses of mental disorders can be combated across contexts. This is a global challenge. And finally, I'll talk to you about briefly about a global public health crisis, and that's suicide. More than 800,000 people die by suicide around the world every year. And in the United States, more than 44,000 people died by suicide in 2014, compared to nearly 16,000 who died by homicide. So the suicide rate in 2014 was more than double the rate of homicides in the US. And in the global context, suicide is the leading killer of girls between the ages of 15 and 19. I share this statistic often because I don't think the global public health community is really aware of the immensity of this problem. Suicide has surpassed maternal mortality in this age group. And this is a real research priority for NIMH. It's also one of the targets of the WHO Comprehensive Mental Health Action Plan, which is trying to get countries to reach targets, one of which is reducing suicide by 2020. And reduced mortality by suicide is one of the indicators for target 3.4 in the Sustainable Development Goals. So 3 reasons why we have to do global research, and I will look forward to talking about more. Thanks.
Thanks so much, Pamela. My first job after internship was with Sir Richard Dahl, who had written the book Cancer on 5 Continents. And today we're going to let Doug talk to us about cancer priorities at NCI. Doug is soft-spoken, he's quiet, but he's made major contribution to the global health agenda through his development with John Schiller of the technology to make the HPV vaccine. And as you know, cervical cancer is one of the leading causes of cancer in women. So Doug, welcome to this audience of people who are interested in global cancer.
Thanks very much, Roger. Thanks everyone for being here today. We are all here because we recognize the importance of global health and from the point of view of research that it can help people who are in other countries as well as help people in the United States. And because of the limited amount of time, I'm going to tell you part of one story which really is around cervical cancer and HPV. The story really starts with the discovery of HPV-16 and 18 by Harold Zerhausen and his colleagues at the German Cancer Research Center in the mid-1980s. And John Schiller and I became involved. We had been studying basic aspects of papillomavirus infection, and we became involved in the 90s to try to see if it would be possible to develop a preventive vaccine against HPV infection. And it turned out that making virus-like particles led to the development of an effective vaccine, but one that has been underutilized up to now, particularly in the developing world and to some degree in the United States. And the research globally has been extraordinarily important for many aspects of HPV infection and the association with cancer. The NCI-supported research has especially focused on Costa Rica because it is a stable country whose highest incidence of cancer in women was cervical cancer. And the initial research that demonstrated epidemiologically that a very high proportion of cervical cancer is attributable to HPV infection was conducted in Costa Rica. And then in order to try to demonstrate that the vaccine works, research, again, a randomized controlled trial of one of the commercial vaccines that was still under development, so it was an experimental vaccine at that time, was conducted in Costa Rica. And the findings of that trial indicated that not only could you get high levels of protection with 2 doses rather than the 3 doses from which the vaccine has been approved, but also post hoc analysis showed that 1 dose conferred a high level of protection. And therefore, again, in Costa Rica, NCI and the Bill and Melinda Gates Foundation are currently embarking on a randomized trial of 2 different FDA-approved vaccines to see whether 1 dose would be sufficient to confer long-term protection in young adolescent girls. What this would do is, first, it would make it much easier logistically to vaccinate people instead of with 3 doses or 2 doses, just a single dose. And the second thing is that it would save a great deal of money. These results would have implications not just in Costa Rica, but in the United States as well as globally. And as Roger mentioned, cervical cancer is actually the number 3 killer of women from cancer globally. About 90% of cervical cancer deaths occur in the developing world. And left to its own devices, because people are living longer, we project that there would be close to a 50% increase in the actual number of deaths from cervical cancer in the developing world over the next 15 years. Currently, it's about 275,000 women per year who die of cervical cancer. So this exemplifies the key role of conducting research in an area outside of the United States that has implications both within the United States as well as globally. I haven't mentioned that it's really not feasible to do this kind of study in the United States, because the key question really is how protective would the vaccine be with these various numbers of doses. And the United States already has partial herd immunity against HPV because the vaccine is being used in the United States. Whereas in Costa Rica, the vaccines are approved, but they are not part of the national vaccine program, and therefore this is a location where it's possible to do these kinds of studies, and really they could not be done in the U.S. So this is just one example where for cancer, doing research in the developing world is key, both for the United States as well as for the world. And there are quite a few other examples which I could give if there were more time. But this, I hope, gives you a sense of really the integration of the research that becomes possible and even necessary, which can be conducted outside the U.S. and have direct implications. Thank you.
So last but not least is Gary Gibbons. Gary's head of the National Heart, Lung, and Blood Institute, so he has 3 different realms of disease in his portfolio. He provides global leadership, Gary, for everything but he trained after training at Princeton, at Harvard, at the Brigham, and Stanford. He ended up going to Morehouse with a Center for Excellence in Cardiovascular Disease and Minority Issues. And I think he's come to NHLBI with this passion. Has actually set up a Center for Global and Minority Health in his institute. So he's working on sickle cell disease in the developing world, household air pollution, and cardiovascular disease, the #1 killer. Gary, tell us about it and why.
Thank you. Well, you just heard our entire agenda, so I guess I can sit back down now. No, it's a thrill to be here because clearly, even as a cardiologist, I've grown up with a perspective that is global, I think, in scope, given that I'm from a population that was derived from outside of this country. You start to appreciate how we are part of one community. And indeed, we appreciate, particularly in these times, that disease knows no national borders, and that science and new knowledge generation and what this research agency is all about creates a public good of information that can have an impact on the patients we care for and the neighbors we live near. And that's something that's true of our entire global community. Our institute, the NHLBI, can't fulfill its mission by itself, certainly not in Washington, D.C. We are part of an ecosystem, part of a circle of partners that are actually essential for us to fulfill that mission. It's really a collaborative effort with you and individuals from all over the world that enables us to do what Congress asked, to provide global leadership, turning discovery into the health of this nation and people in all communities around the world. And it's in that spirit of a global community and partnership that's a delight to be here today. Clearly, I guess I would highlight how our mission really overlaps and converges on the key priorities for us that are intrinsic to our mission. As Roger said, it's the National Heart, Lung, and Blood Institute. And each of those domains has a global dimension to it. In fact, the Institute actually started in 1948 as the National Heart Institute. Didn't have those other disease entities at all. And it was really created in the context of a conversion of the prevalence of diseases happening in the United States. Much like the rest of the world, in the 20th century, we were transitioning from where infectious diseases were the dominant killers in the United States. And it was during that middle part of the century, in the 1940s and 50s, that heart disease emerged as the #1 killer. And there was a critical need to develop a research institute to understand the etiology of heart disease and what could be done to bend that curve backwards. And it's really actually a great story of both the NIH and public health efforts where research investment really have bent the curve such that since that time, there's been a 70% reduction in heart disease deaths in the United States over that period. Again, reflective of research, public health interventions, and advancements in patient care. And in many ways, that's the challenge of the 21st century for the rest of the global community. As, again, the great work that Tony Fauci's done with the Institute has resulted in the control of many of those scourges of infectious diseases around the world, and the emergence now of non-communicable diseases as the #1 killers throughout the globe. And this is our opportunity to provide global leadership, particularly around the areas of what we know works, and developing around an agenda of T4 translational research and implementation science to ensure that, in fact, we can have translate those discoveries into patient care and public health impact in communities all throughout the world. This aligns, in fact, with not only our philosophy about collaborative partnership, but also certain enduring principles and passions that relate to capacity building and promoting the next generation of leaders. And I was taken with the previous element of this program in which your organization recognized that next generation of leaders, the next generation of, it's going to take Tony Fauci's spot here on the dais one day, and that the notion that those leaders ought to come from those countries around the world, and that we ought to be part of training that next generation. I know a passion that I know Roger shares with us. Similarly, we have that enduring principle and passion around this domain of what we're calling implementation science that empowers people, patients, and providers with the opportunities to innovate in ways that can enhance the lives of patients and neighbors and communities around the globe through partnership efforts. And finally, an enduring principle and passion that relates to an evidence-based elimination of health inequities, not only in communities in this country, but around the globe. And again, we believe that these enduring principles are consonant with our mission to turn discovery into health. So how would our approach move in this direction to fulfill our mission? And to a large extent, that relates to a strategic planning process that we've been engaged in, called strategic visioning, in which we've engaged with the community to define a set of critical challenges and compelling questions that we're going to put on our research agenda and prioritize over the next 5 to 10 years. And clearly, our global health agenda is a central core of that. And in fact, we've created a new center in our institute, the Center for Translational Research and Implementation Science. We like to call it CITRUS. And a key part of its agenda is global health. Not surprisingly, another key element relates to health inequities and implementation science and T4 translational research. That confluence of efforts, I think, is very coherent as we prioritize, in particular, where can we be most catalytic and have the greatest impact. And indeed, a priority area for us is a focus on low and middle income countries, and particularly those that have a particular burden of non-communicable diseases that fit our portfolio in heart, lung, and blood disorders. We see an opportunity there because clearly the rise in heart disease. I mentioned that disease has no borders, and neither does our fast food restaurants, the McDonald's and Kentucky Fried Chicken, that have expanded throughout the globe. And with that, some of the challenges of obesity and chronic disease risk factors. Similarly, we now know that environmental exposures affect the lungs. In studies in this country, we've learned that air pollution, ambient air pollution, affects the development of a child's lung. Studies done in California have shown this very nicely. We now appreciate that the lung development doesn't just stop in utero, it actually continues all the way through childhood, adolescence, and maybe even young adulthood, where your alveoli continue to grow and develop. And so exposure to noxious environmental influence can indeed set the stage for chronic diseases decades later. And so it's appropriate for us to ask, well, if that happens in Los Angeles with air pollution, what happens to a child in a low and middle income country where there's household air pollution? And so this is an opportunity for us to not only understand this problem, potentially to have an impact, given the millions of lives that are lost each year, probably related to household air pollution. That's been a collaborative effort with colleagues at NIH, the Global Alliance for Chronic Disease, and the Bill and Melinda Gates Foundation to indeed have an impact. And then finally, I'll just mention sickle cell disease, in which 300,000 babies are born each day with that disease. Again, over 75% of them outside this country, and particularly in sub-Saharan Africa, where this is devastating. Again, similar to heart disease, a scourge that in the 60s and 70s meant that children born in this country often didn't live past high school, where, again, research has made a difference. And the NHLBI has developed efforts to do penicillin prophylaxis, pneumococcal vaccine prophylaxis, chronic transfusion, hydroxyurea, and has dramatically extended the life expectancy of those born with sickle cell disease in this country into middle age. But as we turn to sub-Saharan Africa, again, we see that 85% of the children are dead by age 5. These are imperatives where we as a community of scientists and providers and public health experts can join together collaboratively to address that. And again, I think we will be guided by what we call our 6C approach, in which, guided by our strategic vision, we'll focus in on low middle income countries, the critical challenges and compelling questions that will have the greatest impact on patients and public health. where we recognize in a global health context the importance of customizing our approach related to income, contextualizing what we do, recognizing that one size won't fit all, and the diversity and heterogeneity of various nations across the world in terms of our diseases, that we appreciate that in addition to customizing in context, in many cases we'll have to do a capacity building, as again we work with partners in the LMICs, and for the most part also be cognizant of the importance of allowing this to be a country-driven solution discovery effort, where we leverage the local knowledge and capabilities of those individuals who are going to be able to sustain whatever is developed. So it's really with that set of vision, mission, strategy, and approaches that we look forward to working with you as partners as we address the growing burden of non-communicable diseases in this country and around the world. Thank you very much.
Great. Well, listen, let me ask you this. We're going to have some open questions from the floor, so line up to get questions. And while we're waiting, let me ask a couple questions of the panel up here. I think those were wonderful presentations and introductions. Tony, 25 years ago, or 30, Margaret Heckler in the early 80s said we were going to have an AIDS vaccine in 2 years. And you've done a lot in the last 25 years. Where do you think we're going to be in the next 10 years if we were sitting here on the panel for HIV, Ebola, Zika, and beyond? Where do you see us going?
Okay, so as probably the only one in the room who's ever actually spoken to Margaret Heckler. She's been maligned because she actually did. I mean, I'll get to your answer, but I feel this opportunity to defend it. She never said we would have a vaccine in 2 years. She said we would be testing a vaccine in 2 years. And she was almost right, because the first vaccine trial was actually started in the clinical center at the NIH in 1987 by Cliff Lane. So that was like 3 years after they discovered it. But what she didn't appreciate was the extraordinary difficulty in getting the body to make an immune response against the virus that it didn't like to make an immune response against. And that's the reason why we have an issue with HIV. So I'll answer your questions with regard to HIV. I cannot predict, Roger, when or even if we will have a highly effective vaccine against HIV for any of a number of reasons, the most important of which is the extraordinary, unique situation where the body in natural infection even does not make an adequate immune response, which is contrary to everything we know about vaccinology. I mean, if you look at smallpox, measles, polio, it has its morbidity and mortality, but at the end of the day, the body has given you a proof of concept. It's shown you that it can clear the virus, get it out of the body, and protect you against challenge from the same virus. We don't have that proof of concept with HIV/AIDS. I think we're going to get there, but I don't know how long it's going to take. However, the others that you mentioned, Ebola and Zika, we have vaccines against flavivirus. One of the best vaccines we have is the vaccine against yellow fever. It's 99% effective. So I can't tell you exactly when. We're in a phase 2 trial for a Zika vaccine in a DNA candidate. We have particle inactivated candidates, live attenuated. I think we'll have a vaccine against Zika if there are enough cases to allow us to prove its efficacy. And I think the same thing with Ebola. I mean, we already have an indication that we have what looks like an effective vaccine against Ebola. So I think among those diseases, we ultimately will get vaccines if we put the resources into it.
Great. And Pamela, a couple weeks ago, NPR was talking about studies in Zimbabwe on a mental health intervention that might have implications here in the United States. Could you say something about it? There was one of you, I believe, one of your investigators.
Well, so that's a great question. Dixon Chabanda and his team, they're funded by Grand Challenges Canada, but they're also now doing some work that we're really excited about, which I'll tell you about in a minute. They have been working with how to manage depression in primary care clinics in Zimbabwe. And they started this with a very simple intervention. Rather than needing to refer people to specialist services, of course, there aren't that many options for specialist services, they set up a system whereby you could go outside in a private place, sit on a bench under a tree, and talk to a community health worker. And they call the intervention the friendship bench. And what it is a basic psychotherapy, a kind of cognitive behaviorally oriented therapy called problem-solving therapy that they've trained a number of community health workers, most of whom are older women living in Harare, to do. So they are able to assess people for depression, refer them to the friendship bench. They get the intervention over a number of sessions, and this has been really effective in reducing depressive symptoms. So an effective kind of low-tech intervention that can be integrated into primary care. One of the things we're interested is also seeing, can that same kind of intervention for depression be effective in actually improving HIV outcomes as well in people who are coming to primary care with HIV in terms of improving adherence to care and viral load. So we'll see what we learn as we go forward.
Great, great. Doug, there's this wonderful work now in the book on cancer, the history of cancer, the emperors of all maladies, yes, and which says that cancer is a genetic disease. And of course, the distribution of cancers differs by continent, by geography. Can you say something about the global studies on cancer genome that you're doing, you're involved with?
Thanks, Roger. I think that I would like to divide the research on cancer genomes really into two parts. One is the analysis of the cellular genome, and those analyses involve many countries, and really the notion of data sharing and a federated system so that we can understand the complexity of different kinds of cancers really requires having, if possible, hundreds of thousands of cases so that we can aggregate them and understand them. But I should also point out that global research is being done with infectious agents that are etiologic agents of cancer. And I'd just like to highlight two, which are Helicobacter pylori for stomach cancer and HPV for cervical cancer, because there are some strains that are more oncogenic than others. Using next generation sequencing of thousands of these genomes is providing new insight into really how are these infectious agents carcinogenic.
Mm-hmm. Great. So another demonstration of where global health research is going to be essential to find solutions. And Gary, you've got a big portfolio there with heart, lung, and blood. How do you see us getting the next generation of investigators, many of whom are in this audience, interested and engaged in some of the tremendous problems of the NCD agenda? Where can we go, and how do we get young people involved in research?
Okay, thank you, Roger. Well, some of it really is a collaborative effort with everyone on this stage here. Certainly, the program that you're very passionate about, the MEPI program, something we are also very much engaged in, where we see this as an important part of training and capacity building and a great opportunity. I must admit a certain chauvinism. I don't think there could be more important problems than those that are part of our agenda. So I think those are parts of exciting elements of trying to take on the major scourges that affect people that are in our communities and patients you see every day. And where you know that you can do something that can prevent and preserve life and enhance the productivity of people. So I think those who are attracted to challenging problems that can create solutions is a great opportunity, and certainly we're excited to partner with you and others to support their training.
Great. Well, listen, I see some people standing up. Take the microphones and give us your questions. Give us your name and your institution, and we'll take 2 or 3 questions at a time, and then I'll pass them on to the panel here. First question in the middle here.
Yes, thank you for this great presentation. Michael Reyes from the University of California, San Francisco. And my question is to all the panelists. Given your extraordinary vantage points, do you see any global health imperatives in the realm of sexual and gender minorities? Thanks.
Great. First question, Michael. The next over here.
Quentin Eichbaum, Vanderbilt University. We've heard a lot about low and middle income countries, so my question primarily to Pamela Collins, but also to the other panelists, mostly in the setting of mental health. What about refugee populations? We have a refugee crisis such as we have never seen before. I'm curious what kind of interventions are being made to study the enormous mental health stress those populations must be under. Is it feasible? Is it being done? What are we learning? And what are we learning that might be of value in high-income countries?
Okay,
with regard to
Quentin.
refugees?
Thank you. Next one in the middle.
Hi, my name is Mary White from Wright State University in Southern Ohio, where we have, we think, one of the highest rates of opioid deaths in the nation. And I speak to people around, and folks in Maryland say the same, and folks in Texas and Massachusetts and California think their states lead the pack. We know that part of this is because we teach pain management poorly in medical school in this country. We can assume that there are vast millions of people in the global south whose pain is inadequately treated. We can also assume that narcotics are being moved globally, much as they are within this country. I haven't heard a word about the opioid epidemic in this conference as a global and local problem. I'm mystified, nor have I heard a word about pain management as a global health problem. So here's yet another one I would appreciate some thoughts on. Thank you.
Great, thanks, Mary. And the last one before I refer to the panel, on the
yes.
right.
Oliver Fine from Weill Cornell in Manhattan. For Dr. Gibbons, I just was interested in what you see as the potential breakthrough in the treatment of sickle cell disease, and to what degree that breakthrough would be applicable in Africa.
Okay, let's go back to the panel. Who wants to take the first question from Michael on sexual minorities? Pamela?
Yeah, I think that's a really important population, and one, in fact, that we're learning, certainly in this country, is at a much higher risk of suicide than other communities. And NIH as a whole is developing and trying to stimulate research in this area. A lot of the research focused on sex and gender minorities has been in the AIDS-related portfolio, and I think for the first time, with real effort for outreach to this research community, we're also beginning to support work that is also not explicitly related to HIV. So there's lots to be done, but yes, it's an important community and needs some attention.
And obviously, the issue in sexual minorities and HIV infection is obviously a very important issue. Even though globally, HIV is transmitted as a heterosexual transmission in the overwhelming majority, there are still pockets in different countries in which gender minority is met with extraordinary stigma. In fact, that's one of the things that we're seeing in some countries in Southern Africa, where you have a situation such as in Uganda where homosexuality is outlawed and actually technically is punishable by not only imprisonment, but in some cases death. So, I mean, that's a really important issue when you're thinking about global health of a disease that's one of the big killers in the developing world.
Next question from Quentin was on refugees and the refugee crisis. There's somewhere between 50 and 70 million refugees in the world today in different settings. I don't know if we have anyone here who deals directly with refugees. Pamela, I look at you for the mental health issues involved in dealing with refugees as they transfer from site to site.
Yeah, so certainly another very important population right now, where we typically would expect to see higher rates of mental disorders because of people's exposure to trauma, in particular, high rates of anxiety, high rates of depression. Post-traumatic stress disorder are often observed in refugee populations. One of the, I have two examples of some work that we are supporting at NIMH. As I mentioned earlier, we have been focusing on task shifting. How do we study more abbreviated training in providers to deliver evidence-based interventions? Building on that, having other funders in this space, we recognize that there are some nice interventions out there that are ready to be scaled up in low and middle income countries. we recently started supporting a group of collaborative hubs, we call them, that are focused on scaling up mental health interventions in low and middle income countries. And a couple of those are in post-conflict settings. And in fact, one of them, which is includes Burma, is working in settings where there is active conflict. And they're specifically, that project is specifically working with local NGOs, local clinics in the health system, to figure out the best ways to implement mental health interventions into this variety of treatment contexts. And they are working with communities affected by conflict, some of which will include refugees. So we have much to learn, and certainly there's a demand for this, but I think I also want to encourage people that are working in that area to submit the applications to us, because we need the great ideas coming from you in order to support that kind of research.
Mm-hmm. And we have at Fogarty, supported through our BRAIN initiative, Dr. Molina at Harvard, who works on training and research on mental health and refugee populations. The next question from Mary at Wright State on the opioid crisis and pain management. And I would say, Mary, that we have 27 institutes at NIH. We have one that's devoted to drug addiction. And I couldn't get everybody on the stage today, but maybe next year that would be Nora Volkoff, and I would refer that to her if she were here. Doug, I don't know if you want to say something about palliative care.
Well, certainly pain management of patients with cancer is very important and an area where there's a fair amount of research going on in the United States, and especially in terms of effectiveness as well as patient-reported outcomes and symptom management. Globally, part of the issue has been to be able to disseminate appropriate pain management, and it is complicated in part because of the opioid epidemic and in part because of the sale of opioids across borders, and this has actually interfered with the widespread use of morphine or other opioids for pain management in some countries. My own sense is that this is more a policy issue than a research issue.
Okay. We'll have some more, another round of questions, but let's pardon? Sickle cell, yes.
Yeah.
Last question from Oliver at Weill Cornell on breakthroughs in sickle cell. But other people, get ready for your next round of questions. Sure. Gary.
Yeah, so sickle cell, there are a number of things that I think are emerging. Certainly, there's recent trials NHLBI has funded related to silent strokes in children, which perhaps a fifth of children born with sickle cell disease may have already silent ischemic damage to their brains that affect their cognitive and other effects throughout life. And therapies such as hydroxyurea, chronic transfusions may show some benefit there. Similarly, advances in bone marrow transplantation in the adult population with modifications of treatment strategies that are less morbid than the full-blown bone marrow transplantation is catching on. But I think when we think about the global health setting, I think one of the elements is really to enable what we know currently works in the new context of, say, sub-Saharan Africa. And indeed, we have some initiatives underway in that continent that relate to even the capability of newborn screening to actually diagnose who has sickle cell disease very early on, and then starting to administer things that we do know works in terms of penicillin prophylaxis and perhaps even a pneumococcal vaccine that are not as expensive and are potentially feasible in that context. And so we're working with developing a network in sub-Saharan Africa to look at some of those implementation strategies. And we're hopeful. Ultimately, we're hopeful also that we'll develop small molecule interventions that are indeed scalable on a global way that could be implemented in low middle income countries.
Great. Next question.
Ijeoma Nodim, Internal Medicine Pediatrics, Wayne State University. This question is directed at Dr. Collins, but anyone on the panel is welcome to respond. And this is in regards to mental health, and thank you for bringing that to the forefront, particularly depression and suicide. So we know that physicians are more than twice as likely to die by suicide than the general population, and that female physicians are even more vulnerable. In fact, female physicians are 4 times more likely to die by suicide than women in the general population. I will submit that workers in the global health field are also a vulnerable population just by virtue of the stress and the nature of our work. And then if you're a physician, global health worker, even more so. So I think that's room for research and further study. But my question is, are you aware of any work that has been done to understand this? This is recent data, recent knowledge in the past couple of years, really, that is coming out now. And what work is being done at NIMH to further understand and address this, I would say, epidemic at this time?
Okay. Next question.
Hi, good afternoon. My name is Kathy Tosas Mulligan, and I'm at the University of Illinois Cancer Center. I work under the leadership of Dr. Robert Wynn. And at our Cancer Center, we have a new initiative that we are calling Global Assets and International Alliances, Gaia on Cancer, that is really looking at how we form bilateral partnerships where we exchange assets with other countries. And I'm wondering, for the panel, if there are any formal mechanisms or what are some of the ways in which you are working together to support initiatives that are global health with local impact, where we can bring, for example, lessons learned from working in environments where there's the war-ridden countries, and we bring back concepts around PTSD to address violent communities such as our Inglewood community in Chicago, or looking at Cuba's successes in infant mortality and bringing some of those back to some of our communities most impacted. Thank you.
So your question specifically is?
Are there mechanisms? In what ways are you guys working together potentially to address some of those? Because some of these issues go across the different institutes.
Okay, creating international collaborations, if you will. Next question.
Anya Grushin, ophthalmologist from Loyola University in Chicago and volunteer oculoplastic surgeon working in Asia, Africa, and Oceania, representing the Himalayan Cataract Project. So I've been a privilege to be at this meeting and to have this panel representing many branches of NIH. And I was wondering the role of NEI and ophthalmologists that are working globally. How can we partner together with the medical and surgical subspecialties to address, I think, a significant need where access to care is limited by patients not being able to see to get to their medical provider, not being able to take their medications appropriately, things like that. So where can we collaborate, and how can we start that discussion?
Okay. And Afaf?
Afaf Milis from School of Nursing at the University of Pennsylvania. So first, thank you very much, Roger, for bringing this fantastic panel. I feel that global health research is in good hands among all of you. My question to you is for people in this audience who are preparing themselves for global health research. What advice would you give the young people, the young fellows, the future scholars, to prepare themselves for research in global health? What strategies should they follow now to be prepared for that for the future?
Great. So let's go back to the panel. The first question was about suicides in female health workers. Pamela, that's a risk factor that I never thought of before.
Yeah, that's a great question, and certainly an important group to think about, the caregivers who are delivering medical services. So, as I mentioned before, suicide prevention is a huge priority for NIMH. However, I don't think we have any specific studies focusing on that specific question. However, One of the side benefits of supporting global research is that you have investigators who propose a particular study, and then one of the things that we found important as we fund global research is to include a research capacity building component of that. So as it happens, one of our investigators who's working in Brazil on interventions for people with depression, hypertension, and diabetes also has a larger group of trainees that are working on other questions relevant to mental health. And they have been looking at depression in primary care providers in Brazil and recognizing high rates of depression in primary care providers. So most of that work has been more descriptive in showing that yes, this is a problem and that it can likely affect the way that providers in those contexts where they're overworked, they have a high patient load, well, this affects the quality of care that they provide. But I don't think yet that they are at the stage of thinking about specific interventions for that group. But yes, really important question. Again, with all of those important questions, talk to us. Think about the research concept that you might want to take a stab at and start the research.
Great. Next question was from Kathy about arranging global health collaborations and exchanges. And I would say that this meeting, the CUGH, is an ideal place where people are getting together and networking. And you have here, Kathy, some of the, many of the major collaborating centers that do global health research. So I'd ask you to hobnob with them. I think each of us is involved with centers of excellence in cancer and heart disease and infectious disease and mental health, and Fogarty as well. Does anybody want to address that specifically, or should we? I think I answered it. For ophthalmology, as I said before, we have 27 institutes. One is the NEI, and they've been very engaged in global health research, but around things like the follow-up of eye disease from Ebola patients, diabetic retinopathy in India, but the head of that institute's not here, but we might ask him at the next CUGH meeting. So I would ask you to hold that question or write to them directly. I don't know if anybody up here is in a position to answer that. And the last from Afaf would be advising young people about strategies and engagement. I think that's something that we're really all involved with in training through programs at Fogarty, through T32 programs, through each of the institutes here. Don't know how to be more specific on that question as well. Any takers?
My feeling is one size does not fit all, and that it really depends on what you are really passionate about and where you see the potential for having impact. And some of it also is opportunity. Where can you have an experience where you can be working in the area of global health? And my own feeling is that it could be especially useful to have some on-the-ground experience, regardless of what one is doing. But because global health is really encompasses so much, I'm not sure that it's possible to give a single, simple answer.
I would just give a pitch for the Fogarty program for fellows and scholars, where we send about 80 students and fellows to a year of mentored research in any of these fields at NIH. I think there's 16 partners where you can go and have a mentored research experience, and that really gets people engaged early in their careers, and 80% of them will go back and continue to do something in global health. Yes.
Yep, Roger?
Yes.
So just to point out that the whole arena and field of global health is very much alive and well in the desires and needs of young people coming up through our program. It's astounding if you look at, we have a system in NIAID that when the fellows come in each year, whether they want to work with me or not, they all come through and sit down for an hour or so and talk about career development. And I'm amazed over the last several years of the keen interest in such a relatively high proportion of these young people to get involved in global health. And what I tell them is essentially what Doug said, that one size does not fit all, but also to try and get some on-the-ground experience, because the opportunities are there. We just need to just continue to encourage young people to do that.
Great,
Yeah,
Pamela.
And I agree with both of them. I think, first of all, asking people, what do they mean by global health? And often it's not that well formulated, and helping young people to formulate what kind of experience they really are trying to have. One of the things we worked hard to do at NIMH over the last few years is to create a career path. So you could do the Fogarty Global Fellows and Scholars. You could complete that if you are in medical school, finish your residency. Then you can do a postdoctoral research fellowship. We have institutional fellowships focused on global mental health now at 3 universities around the US. And if you include our HIV/AIDS related global research, that expands the number of opportunities. We then instituted a Global K Award for mental health research just to stimulate that area and get people thinking about it. And now it's pretty common for global mental health interest to be just included in our normal career development award pool. So we've got a nice little pathway for people who are interested in mental health research.
So let me take these last 3 questions, quick answers, and I'll give the panelists each a minute to give us a final concluding remark. So start in the middle here.
Hi, I'm Bhakti Hansodi. I'm from Johns Hopkins, and I work on emergency medicine-based HIV testing in the Eastern Cape region of South Africa. So all of you have talked about global health and the need to build implementation science methodologies to deliver healthcare interventions. My question is, do any of your institutions provide implementation science training, or is there a desire to make those available to extramural researchers?
Okay, next question over on the right. In the middle.
Hi, I'm Rosemary Morgan from Johns Hopkins Moodbook School of Public Health. My question is whether sex-based and gender-based analysis is a priority in NIH, and if so, how do you ensure it is mainstreamed in all your programs or funded research? And I just have, draw your attention, we have an extra question behind me that you might not see.
Hi, my name is Sarah, and my question is, this generation's life expectancy is lower than the previous generation. Why do you think this is?
Great question, Sarah. Very good question. Let's go down. Let's have quick answers.
Roger, can I ask one question?
Sure. I can't see you, though.
Michelle Berry from
Yes.
Stanford over here. So I have a question to the Institute leaders. If in our worst dreams, this skinny budget comes through and Fogarty is limited, are you all willing to step up and put $30 million up? And how's Roger?
Well, that was a great question, Michelle. I don't know.
Did you plant that one, Roger?
I did not plant that question, no. We'll take that question last, I guess, Michelle. Fatima, about testing in South Africa, training and implementation science. I know we at Fogarty have a program in implementation science in our institute, and you can look at the RFA for that on our website. I think some of the other institutes have it as well.
Yeah, we have extramural institutional research training in implementation science. One of those programs has been at Washington University for quite a long time.
Yeah, NCI has awards specifically that can be included in that area, and also we have the NCI designated cancer centers. There are 69 of them, and a subset of them have very strong programs in implementation science research training.
Yeah, at NIAID, the partnership that we've developed with PEPFAR over the last several years in getting actually PEPFAR money to do implementation science in synergy with what we do in our general clinical trials and other has led to a training program that now teaches people about implementation science, which was brand new to us before because we never had to do it.
Okay, the next, thank you. The next question was on minority health and sexual minority health. we have an institute of National Institute of Minority Health. There's an office of LGBT and T, but there's an office. Pamela, can you help me with that?
There's a new office on sexual and gender minorities in the NIHOD. So, and that group has been spearheading some trans NIH program announcements that I think a number of institutes are involved in. I think if that's, I'm actually sorry, I might have missed a question, but I think the other question was around the importance of sex and gender as part of our analyses. And that's a huge priority at NIH. Certainly there's an effort to look at sex as a biological variable. That focuses on some preclinical research, but we're all required, in fact, to track how well we're doing with recruiting women, minorities, into our studies at NIH. So this is something that all of the institutes are actively involved in. I think one of the things that we certainly want to encourage people to do is when they're ensuring that they're enrolling women and enrolling ethnic minorities, is that they analyze the data that they've collected from those different groups so that we can really get the best understanding of how there may be differences by gender, sex, and race and ethnicity.
Sarah wants to live longer in her generation. What can we do to help her? Sarah, eat well, exercise, don't drink sugar-sweetened beverages.
Well, I guess one perspective is I'm delighted that Sarah's has that interest at her age, because what we're learning more and more is that the chronic diseases we always thought as diseases of aging that happen in middle age in our portfolio actually probably start in utero. And so the seeds are sown then for the developmental trajectory for the development of chronic lung disease and cardiovascular disease. So indeed, how well what you ate and slept as a parent for that child in utero, and indeed all throughout childhood is really putting you on a trajectory. So you not only want to develop those habits, but develop them extremely early.
Great, and Michelle's last question, I don't want to let them off the hook, but all of these groups are partners with Fogarty on many of our programs, but you might each want to say something to satisfy Michelle's query.
Up until now, Fogarty is a key integral part of NIH, and I think that it would be, we need to see what happens with this proposal. But to me, the key part is also that Roger has really done an amazing job leading Fogarty, and international global research will continue to thrive.
I guess I would not only add, again, an endorsement of Roger's leadership, but also probably state the obvious Civics 101 lesson that a skinny budget by the president is one element of the process, and that a proposal is that we receive our appropriation from Congress, and so that's still a subsequent element of the process that I would stay tuned for, and I can speak for the NHLBI that clearly we are committed to a global health agenda, and we appreciate Fogarty's leadership, its ability to coalesce and be a focal point for global health, but certainly the agenda that we outlined, we are committed to. Obviously, our progress and our pace will be slowed by any budget cuts, but the commitment is steady and persistent.
And I think I can speak for all of our institute directors to say that the Fogarty International Center is a very, very important part of the NIH, and if anyone knew anything about the Fogarty Center, they would want to do everything to make sure that the Fogarty Center stays the way it is.
And actually, let me also just take this opportunity to say that Josh Gordon, who is the NIMH director, sends his regrets. He would have liked to have been here, but he's not able to be here today. But I will say, from the NIMH perspective, is that Fogarty has been an amazing partner for us. We have really, we're one of the newer global health programs in terms of our level of investment in global global mental health research and training, and Fogarty has been a real base for enabling us to do research capacity building. So we value this collaboration incredibly and have been able to leverage so much based on what Fogarty has provided.
Yeah, but Roger, also, if you look, and I think many people in the audience know this, but if you look at the public health leaders in the developing nations throughout the world, it's stunning how many of them were Fogarty trainees at one time in their career. I mean, multiple ministers of health. It's extraordinary.
Thank you all for those wonderful closing words, and I think we've used up our time. We've used up our time before the coffee break. So let me thank you all for coming this afternoon on a beautiful Saturday afternoon in Washington, and thank the audience for staying with us on this lovely afternoon. Thank you.